hypoglycemia in patients with DKA. But if the patient has respiratory failure, it's probably worth considering because muscle weakness is the primary manifestation of hypophosphatemia. This flowchart is a reasonable approach to the management of a patient with diabetic ketoacidosis. It's described as the DKA approach, a useful mnemonic to treat diabetic ketoacidosis. We'll go through the essential elements in some detail on subsequent slides. Delaying surgery to eliminate ketoacidosis is counterproductive if the surgical condition is creating a problem. Stabilization of the patient, however, is warranted. The first step in management is to treat the dehydration. The volume deficit is generally 3 to 5 liters, but maybe as high as 10 liters. Volume expansion needs to be moderately aggressive. Most recommend replacing 1/3 of the deficit in the first 6 to 8 hours and the balance over the next 24 hours. Remember, patients with diabetes probably do not have normal ventricular function. In patients with a history of significant myocardial dysfunction, monitoring intravascular volume may be prudent. The second step is to treat the potassium deficit, which is commonly in excess of 3 milliequivalents per kilogram and may be as high as 10 milliequivalents per kilogram. Think about that. In a 70-kilogram person, you are talking 210 to as much as 700 milliequivalents of potassium. That obviously cannot be replaced quickly. Additionally, urine output should be restored before administration of potassium. This algorithm says the serum potassium must be corrected before insulin is administered. As previously noted, the potassium deficit is not something that can be corrected by potassium administration, even in a day. Instead, I would say that the hypokalemia needs to be addressed prior to administration of insulin. Once insulin therapy is initiated, the serum potassium is likely to decrease as it moves into the cells. Remember, glucose and insulin are one of the treatments for hyperkalemia. The potassium is not lost from the body. In addition, however, as the intravascular volume is expanded, more sodium is delivered to the distal tubules of the kidney, resulting in potassium loss. Obviously, that potassium is lost from the body. Treatment of the acidosis begins with the administration of insulin. Most authors recommend an initial bolus followed by a continuous infusion. During the first 2 hours, with volume resuscitation, glucose levels may fall precipitously. In general, the maximum rate of decrease in serum glucose is about 75 to 100 milligrams per deciliter each hour. This occurs because there are a limited number of insulin binding sites. Once the serum glucose declines to 250 milligrams per deciliter, glucose should be added to the IV fluids. As previously noted, DKA results in an anion gap acidosis. Factors contributing may include ketones from the ketoacidosis, lactate from hypoperfusion secondary to hypovolemia, or organic acids from renal insufficiency. Treatment of acidosis with sodium bicarbonate is controversial. On the one hand, increasing pH to greater than 7 clearly improves myocardial function. On the other hand, rapid correction of acidosis may cause central nervous system problems due to paradoxical worsening of CSF and central nervous system acidosis. This may occur as bicarbonate is converted to carbon dioxide and diffuses across the blood-brain barrier. Other contributing factors potentially involved in the paradoxical acidosis include decreased cerebral blood flow and development of osmotic gradients between the blood and brain. Now let's look at the perioperative management of hyperglycemia. Prior to 2000, it was common to not treat hyperglycemia unless the blood sugar was greater than 250. In 2001, the Vandenberg study reported a decrease in mortality in ICU patients if the serum glucose was maintained between 80 and 110 milligrams per deciliter, compared with a target of 180 to 200. Despite many people pointing out the limitations of this study, for example, it was not possible in routine clinical care to duplicate the intensity with which the patients were monitored during the study, several government agencies and the American Diabetes Association adopted the recommendations advanced by Vandenberg and used them as an indicator of quality. In the first few years after the Vandenberg study was published, a series of other studies were published which failed to document any difference in mortality, but did demonstrate that as many as 28% of patients managed according to the tight glycemic control guidelines developed significant hypoglycemia. In 2009, a study involving over 6,000 patients in over 40 centers was published. The study used an algorithm known as NICE Sugar, which stands for Normal Glycemia in Intensive Care Evaluation, Survival Using Glucose Algorithm Regulation. That study documented that not only did adherence to the target of tight glycemic control result in an increased incidence of hypoglycemia, odds ratio 14.7, p less than 0.001, but also documented an absolute increase in mortality in these patients, odds ratio 1.14, p equals 0.02. Subsequent meta-analyses have reported no overall effect on mortality for patients managed along the tight glycemic control guidelines, but an absolute increase in the frequency of hypoglycemia. Current recommendations from the American Association of Clinical Endocrinologists and the American Diabetes Association is that insulin infusion not be initiated unless blood sugar is greater than 180, and that once an insulin infusion is started, the target should be 140 to 180. This table is from an article in Anesthesiology published in 2017. You might want to pause the presentation here to review the table, but there are a few things that might simplify it. First, for everything other than the non-insulin injectables, the recommendations are not altered by whether or not the patient has had a bowel prep or clear liquids only for 12 to 24 hours pre-op. Second, if a dosage reduction is recommended, the recommendations are to give 80% of the usual dose. Finally, only for NPH insulin do the recommendations include a reduction in the morning dose. This is a one-part session on lung ultrasound. This session is actually a combination of keywords from two collections, respiratory and anatomy. It made more sense to me to combine them into a single presentation, so I've taken the liberty of doing that. I'll start with ultrasound anatomy of the normal lung. This includes not only normal findings, but also the appropriate techniques for lung ultrasound. Although lung ultrasound may be performed with a linear, curvilinear, or phased array probe, the linear probe is best when examining more shallow structures, for example, the pleura looking for sliding, and the curvilinear is best when looking for deeper structures, for example, when looking for B-lines. This ultrasound demonstrates a normal pleural line. It appears as a horizontal, hyperechoic structure below the ribs and represents the interface between the visceral and parietal pleura. The image produced by the ribs with their acoustic shadowing and the hyperechoic pleural line has been termed the bat sign. line is supposed to represent the body of the bat, and the two ribs represent its wings. No matter how hard I look, I don't see a bat in that, but if you do, more power to you. Your imagination is obviously better than mine. Disclaimer, I am not an artist. This illustration attempts to show the transducer, skin, gel, ribs, and pleura, all of which are labeled. A-lines are a classic example of reverberation artifact. In this sequence, the transmitted beam, blue, strikes the pleura, green, and is reflected in the transducer, red dotted line, which generates the image of the actual pleura as a hyperechoic line. The original ultrasound beam also bounces or reverberates between the skin and the pleura, as shown by the red arrow. Some portion of the reverberated beam is also reflected in the transducer, as shown by the pink arrow. Remember that the ultrasound machine determines the depth of an object, orange arrow, based on how long it takes the reflected signal to be returned to the probe. Because the reverberated signal takes approximately twice as long as the reflected signal from the original beam, as indicated. This ultrasound demonstrates an A-line. As previously described, it is a reverberation artifact of the pleura, which appears as a horizontal line at a depth that is a multiple of the distance between the skin and the actual pleura. There are several characteristics of A-lines. First, they are identical in shape to the pleural line. Second, they occur at regular intervals deep to the pleural line. And finally, the brightness is diminished with each replication. Lung sliding represents the motion of the visceral pleura over the parietal pleura. By definition, lung sliding is a dynamic process. As shown in this video, it appears as shimmering or sliding between the two layers. Normal lung sliding may be represented by a still image obtained in M mode, the results of which are termed the seashore sign. Ostensibly, the parallel lines at the top of the image, indicated by the blue arrow, represent waves, and the granular texture below the pleural line, indicated by the red arrow, represent the sandy shore. These are the images that will be addressed in this section. While not exactly pathologic, a mirror image artifact merits at least a brief comment. Watch this video. Notice that below the pleural line moves, there is no shimmering or sliding evident. This indicates the absence of lung sliding. Notice the difference between the motion of the pleural lines on the two videos. The video on the left clearly shows back and forth movement on the pleural line, which is absent from the video on the right. Lung sliding is present on the left, but absent on the right. This is an M-mode image that occurs in the absence of lung sliding. Termed the barcode or stratosphere sign, the area below the pleural line shows parallel lines essentially indistinguishable from the area above the pleural line. Here's a side-by-side comparison of the seashore sign and the barcode sign. Notice that the differences are confined to the area below the pleural line. Obviously, the first prerequisite to see lung sliding is that the lung underlying the probe must be receiving ventilation. An esophageal intubation, apnea, or intubation of the contralateral main stem bronchus will all result in the absence of lung sliding. Also, the interposition of anything between the visceral and parietal pleura will result in the absence of lung sliding. Examples obviously include air or blood. Finally, although perhaps not common in the general population, a pleurodesis or a prior thoracic surgical procedure which resulted in scarring between the two layers of pleura will also result in the absence of lung sliding. This video demonstrates what's termed a lung point. Notice that no lung sliding is present to the left of the red arrow, and the lung sliding is sometimes present to the right of the red arrow. Here's another video that demonstrates a lung point. No lung sliding is evident to the right of the red arrow, and is sometimes present to the left of the arrow. A lung point identifies the point at which the visceral and parietal pleura become separated in pneumothorax. When imaged in M mode, a lung point presents as a seashore sign, alternating with the barcode or stratospheric sign. As already noted, the absence of lung sliding can be caused by a variety of conditions. The presence of the lung point is essentially pathognomonic for a pneumothorax. Watch this video for 4 or 5 seconds and answer the question of whether lung sliding is present or absent. While there is clearly motion of the pleural line, it is synchronous with the heart rate, not the respiratory rate. This is termed a lung pulse. This M-mode image of a lung pulse clearly demonstrates that the image alternates between a seashore sign, blue arrow, and a barcode sign, red arrow. The presence of a lung pulse indicates that the underlying lung is not being ventilated. Another potentially pathologic finding on lung ultrasound are B-lines. B-lines are the result of widened intralobular lung septa and permit propagation of ultrasound waves. This image shows multiple B-lines. By definition, B-lines are hyperechoic, discrete, begin at the pleural line, move with lung sliding, extend to the periphery, and obliterate A-lines. Notice how these characteristics are present on the adjacent image. While not a great image, this video shows B-lines moving with lung sliding. Since a normal lung fissure may result in a B-line, to be considered pathologic, there must be 3 or more B-lines in a single interspace. The presence of B-lines under the probe is consistent with anything that causes widening of intralobular septae. Limitation of B-lines to one area of the lung, for example the right lower lobe, is consistent with a localized process, pneumonia. The presence of B-lines throughout both lung fields suggests more generalized pathology, for example pulmonary edema. Next, we'll talk about the spine sign. Here's an abdominal ultrasound showing the diaphragm, liver, and kidney, all of which are labeled. This image actually shows two pathologic features. Although not relevant to the discussion of lung ultrasound, the blue arrow indicates Morrison's pouch, the potential space between the liver and the kidney. The liver and kidney should be immediately contiguous. The fact that there is a hypoechoic area between these two structures is consistent with some form of free fluid in the abdomen. What's more interesting from the perspective of lung ultrasound is what's termed the spine sign. Normally, presence of air in the lungs results in the inability to visualize the spine above the diaphragm. This image clearly shows the spine both above and below the diaphragm. The ability to see the spine above the diaphragm is indicative of the fact that something which transmits ultrasound, most likely fluid, is located above the diaphragm. Now it's time to discuss mirror image artifacts. Here's another abdominal ultrasound. Although it won't be the basis of this discussion, note that, unlike the prior abdominal ultrasound, there is no hypoechoic stripe in Morrison's pouch, the area between the liver and kidney, as indicated by the blue arrow. Notice the area indicated by the white arrow above the diaphragm. What does that resemble? The liver? That's exactly right. No, the patient doesn't have liver above the diaphragm. This is an example of mirror imaging artifact. This is perhaps a better example of a mirror image artifact. Ideally, what happens is that the ultrasound beam, exemplified by number 1, strikes the diaphragm and is returned to the probe, where it is interpreted as a hyperechoic line. In practice, however, some of the beam is reflected from the diaphragm, as represented by the second arrow. In this case, it strikes a cyst, labeled C, is reflected back to the diaphragm, as represented by arrow 3, and from there back to the probe, arrow number 4. Because the probe calculates distance based on the amount of time it takes the ultrasound waves to be returned, it shows another cyst above the diaphragm. Note that this mirror image artifact is shown at the same distance above the diaphragm, represented by arrow number 6, as the actual cyst is below the diaphragm, represented by arrow number 2. This is part 2 of selected respiratory keywords for 2019. As previously mentioned, Dr. Scheld has 2 sections on respiratory keywords. These are the keywords I assigned. See part 1 for content related to pulse oximetry, Kaplan waveforms, and the oxygen-Wilbon dissociation curves. This section will focus on lung compliance and oxygen content, oxygen delivery, and oxygen consumption. I have an entire presentation related solely to lung compliance and airway resistance. I will try to focus on the highlights, especially as they relate to potential exam questions in this videocast. Compliance, the change in volume divided by the change in pressure, is a measure of how easy it is to get gas into the lungs. Although the concept can be applied to spontaneous ventilation, as anesthesiologists we think of it almost solely from the perspective of positive pressure ventilation. This is a normal pressure volume loop. Note that lung volume increases as transpulmonary pressure increases during inspiration. Conversely, lung volume and transpulmonary pressure both decrease during exhalation. The slope of the line between the onset of inspiration and the onset of exhalation is the static compliance of the respiratory system. There are 2 components of respiratory system compliance: the compliance of the chest wall, which includes the rib cage and the abdomen. Decreases in chest wall compliance may be due to anatomic deformities, such as kyphoscoliosis, pathology involving the thoracic wall, such as extensive burns with scarring, or decreases in abdominal compliance, such as obesity, pregnancy, or the prone position with inadequate support of the surrounding structures. Pneumonia or pulmonary edema are classic examples of conditions that cause a decrease in compliance of the pulmonary parenchyma. These 2 pressure volume loops demonstrate increased and decreased compliance, respectively. Note that neither the loops nor the calculated value for compliance allow determination of the etiology of the decreased compliance. That is, decreased compliance could be due to decreased compliance of the pulmonary parenchyma or decreased compliance of the chest wall. It cannot be determined from either of these curves. This graph illustrates that, to some degree, compliance is a function of lung volume. At low lung volumes, units become atelectatic, resulting in an increased pressure, decreased compliance required to open them. At high lung volumes, lung units are non-compliant because they are overdistended. The subject so far has been the compliance of the lung and the chest wall. It must be understood that when the pressure generated by the ventilator during positive pressure ventilation is used to calculate compliance, the result is dynamic compliance. Peak inspiratory pressure, the pressure used to calculate dynamic compliance, is determined by resistance, compliance, and PEEP. The problem with this is that an increase in airway resistance can result in a high peak airway pressure, resulting in a low value for dynamic compliance, when the reality is that the compliance of the respiratory system, that is, of the lung and chest wall, is normal. To truly assess the compliance of the respiratory system, the value of the static compliance must be determined. To do that, the plateau pressure must be used. Plateau pressure is the pressure generated during an inspiratory pause or an inflation hold. Since by definition, flow equals 0 during the inflation hold, that is, no additional gas is being added to the respiratory system, resistance is no longer a consideration. It doesn't matter how large the value for resistance is. If flow is 0, the product of the 2 is 0. Now there's a basis for determining the etiology of an increase in airway pressure. Presumably PEEP hasn't changed, so that factor can be disregarded when attempting to determine the etiology of an increase in airway pressure. Accordingly, since peak inspiratory pressure is determined by resistance and compliance, but plateau pressure does not include airway resistance, the etiology of the increase in peak inspiratory pressure should be obvious. Here's an example. If the peak inspiratory pressure is elevated, it's not possible to determine if this is due to an increase in airway resistance or a decrease in lung compliance. Adding an inspiratory pause or inflation hold has the potential to help make the diagnosis. If the plateau pressure is only slightly lower than the peak inspiratory pressure, the problem is due to a decrease in compliance. In this circumstance, consideration must be given to factors causing a decrease in compliance, including a pneumothorax and a main stem intubation. If the plateau pressure is dramatically less than the peak inspiratory pressure, the problem is most likely due to an increase in airway resistance, and treatment should focus on resolving that problem. It should be noted that the use of static and dynamic compliance can facilitate the determination of whether a high peak inspiratory pressure is due to an increase in airway resistance or a decrease in compliance of the respiratory system. It cannot determine whether a low compliance is due to problems with the lung or problems with the chest wall. The next subject relates to oxygen content, oxygen transport, and oxygen consumption. Oxygen is carried in blood in two forms. It's bound to hemoglobin, and it's dissolved. Notice a couple of things. First, under normal conditions, the dissolved oxygen represents less than 2% of oxygen content. Second, a blood gas only measures the dissolved oxygen. Here is the standard formula for calculating the oxygen content of blood. We can argue about the most accurate value for this constant, the oxygen carrying capacity of hemoglobin, but I prefer to use 1.34 because it's approximately 4/3. This allows me to do almost all the math in my head. Furthermore, that number will produce not only a clinically relevant result, but it will also allow you to get the correct answer on any question I have ever seen. Also note that this is the fractional saturation of oxygen. That is, if the oxygen saturation is 100%, the number is really 1.0. Notice that the first part of the equation calculates the amount of oxygen that is bound to hemoglobin, while the second part of the equation calculates the amount of oxygen that is dissolved in plasma. Now let's do some calculations. Assume a hemoglobin of 15, an arterial PO2 of 100, and a resulting saturation of 100%. Substituting these values into the equation results in this. This makes it obvious why using a value of 1.34 for the oxygen carrying capacity of hemoglobin is an advantage. 1/3 of 15 is 5, times 4 is 20. 0.003 times 100 is 0.3. So this results in an arterial oxygen content of 20.3 milliliters of oxygen per deciliter of blood. Obviously, almost all of this, 20 milliliters per deciliter, is bound to hemoglobin. The significance of this becomes evident as values for hemoglobin and PO2 are changed. So if the patient's hemoglobin is 9, what happens to the oxygen content? 1/3 of 9 is 3, times 4 is 12. So this patient has an arterial oxygen content of 12.3 milliliters of oxygen per deciliter of blood. Note that the partial pressure of oxygen in arterial blood did not change. Accordingly, there is no change in the amount of oxygen dissolved in the blood, but there is a 40% decrease in the oxygen content. What happens to the oxygen content if the patient's hemoglobin is 7.5? 1/3 of 7.5 is 2.5, times 4 is 10. So this patient has an arterial oxygen content of 10.3 milliliters of oxygen per deciliter of blood. Again, there is no change in the partial pressure of oxygen in the blood, despite a 50% decrease in the arterial oxygen content. Here are the numbers side by side for comparison. Notice that decreasing the hemoglobin concentration by 50% also decreases the arterial oxygen content by almost 50%. What happens if the partial pressure of oxygen in arterial blood is decreased by 50%? With a normal oxyhemoglobin dissociation curve, the saturation with a PO2 of 50 is slightly more than 80%. Do the math. 1/3 of 15 is 5, times 4 is 20, times 0.8 is 16. In this circumstance, even though the partial pressure of oxygen is reduced by 50%, there's only about a 20% reduction in the arterial oxygen content compared to a PO2 of 100 milliliters of mercury. Here's the bottom line with the numbers side by side for comparison. Notice that decreasing the hemoglobin concentration by 50% also decreases the arterial oxygen content by almost 50%. But decreasing the partial pressure of oxygen in arterial blood by 50% only decreases the arterial oxygen content by 20%. The next subject is oxygen delivery. Here's the formula for calculating O2 delivery. We just calculated the value for oxygen content, and the other values are straightforward. Obviously, for the calculations to be correct, it's critically important to remember to include the factor to adjust for the fact that the formula used to calculate oxygen content determines the content in milliliters per deciliter, but the cardiac output is presented as liters per minute. Here's the math. Assume a hemoglobin of 15, an arterial PO2 of 100, and a cardiac output of 5. From our prior calculations, we know that the arterial oxygen content under these conditions is 20 milliliters of oxygen per deciliter of blood. So the math is very simple. The normal value for oxygen delivery is approximately 1,000 milliliters per minute. What happens with a 50% reduction in cardiac output? The arterial oxygen content is still 20 milliliters per deciliter, but the calculated value for oxygen delivery is reduced by the same percentage as the cardiac output. Here's a side-by-side comparison of the impact on oxygen delivery of a 50% reduction in hemoglobin, cardiac output, and the partial pressure of oxygen in arterial blood. Notice that decreasing the hemoglobin concentration by 50% or decreasing the cardiac output by 50% result in a 50% decrease in oxygen delivery. In contrast, decreasing the partial pressure of oxygen by 50% only decreases the oxygen delivery by less than 20%. The take-home message from this is that a decrease in the partial pressure of oxygen in arterial blood has less of an impact on oxygen delivery than a comparable decrease in cardiac output or hemoglobin concentration. The next subject is oxygen consumption. When thinking about oxygen consumption, it's easiest for me to think about calculations based on the Fick equation. I like this approach not only because it's very logical, but also because it reinforces the previously discussed concepts of oxygen content and oxygen delivery. If it helps, oxygen consumption can be considered as the amount of oxygen delivered minus the amount of oxygen that remains. Think of it as something of a balance sheet that's analogous to your income and your expenses. You know how much money you earned last month, and you know how much money you have left in your checkbook at the end of the month. So by subtracting one from the other, you know how much you spent. To calculate oxygen consumption using the Fick equation, we must determine the mixed venous oxygen content. The formula for mixed venous oxygen content is simply the formula for arterial oxygen content, but using values for mixed venous blood instead. By the way, to accurately measure mixed venous oxygen, blood must be sampled after it's gone through the right ventricle, that is, in the pulmonary artery. The reason for that is because streaming of blood can occur in the right atrium, so the sample may not actually be mixed venous blood. Fetal circulation provides an example of streaming that occurs in the right atrium.